Hello everybody. Before moving on to today's session, I want all of you to look into this question and try to find the correct answer. You can pause the video if you want, and later in this video we'll discuss about it. Hello everybody. In this video, we're gonna learn about shock. Shock is a life-threatening fall in the blood pressure. Now we know blood pressure is equal to the product of cardiac output and total peripheral resistance or systemic vascular resistance. So whenever there is fall in the cardiac output or fall in the total peripheral resistance or both, then there is fall in the blood pressure. And if this is severe, this might lead to shock. Now the fall in the cardiac output might be due to loss of contractility of the heart, where the heart cannot pump enough blood out, so there is fall in the cardiac output. Or it might also be due to low intravascular volume. So the blood volume itself might be low, so there is fall in the cardiac output. The fall in the total peripheral resistance might be due to peripheral vasodilation, and all of these conditions will lead to shock where there is low tissue perfusion, which can further complicate as multi-organ failure. Now let's talk about the types of shock. There are 4 different types of shock. The first one is cardiogenic shock. In the cardiogenic shock, there is defect in the heart itself. Okay, so the heart ventricles cannot contract and pump enough blood out, so the cardiac output is going to be low, and this is seen in cases of myocardial infarction. In the hypovolemic shock, as the name applies, there is less intravascular blood volume. So as the volume is low, the cardiac output is going to be low, and a classical example of this is hemorrhage or massive bleeding. In the third one, we have distributive shock. In the distributive shock, the cardiac function is normal, the blood volume is normal, but there is problem in the distribution of the blood to the peripheral tissues. Okay, so the major problem here is the peripheral vasodilation. As the peripheral vasodilation, the blood vessels, they become leaky, and there is problem in perfusing the tissues. And if it is due to infection or sepsis, we call it as septic shock. If it is due to any allergic reaction, we can call it as anaphylactic shock. The last one is the obstructive shock, where there is obstruction in the outflow of the blood, and we'll talk in detail about this later in the video. Now it's very important to determine the types of shock because there are different treatments for different types of shock. Okay, so we need to determine the types of shock and we need to treat them accordingly. Now often the types of shock can be determined from the history only. If there is a history of myocardial infarction, then the patient is most probably having cardiogenic shock. If there is a history of hemorrhage or massive bleeding, then he or she might be having hypovolemic shock. Okay, but in certain scenarios, if there are no history or if we don't know the etiology, then we can determine the types of shock by measuring the cardiac pressure and the mixed venous oxygen saturation. Okay, so we can determine the types of shock by measuring these 2 parameters, the cardiac pressure and the mixed venous oxygen saturation, and these are measured using a device known as Swan-Ganz Catheter. Okay, so later in the video we'll talk how we can analyze these 2 parameters to determine the types of shock, but now let's see how the Swan-Ganz Catheter is used to measure these parameters. Swan-Ganz Catheter, also known as pulmonary artery catheter. Okay, so it has this is the catheter, and in the tip of this catheter it has this pressure sensor which can sense the pressure. Okay, and just below the tip there is a portion where the balloon can be inflated. Okay, so the balloon can be inflated just below the tip of the catheter. Okay, so the Swan-Ganz catheter is inserted inside the chamber of the heart through the central venous line, and when it reaches into the right atrium, this pressure sensor, the tip of the catheter, can measure the pressure of the right atrium. So it can measure the pressure of the here in the right atrium, and while on the right atrium the balloon is inflated, and this catheter is taken along in the direction of the blood flow into the right ventricle, and now in the right ventricle the catheter can measure the pressure of the right ventricle. From the right ventricle it is taken along to the pulmonary artery, and in the here it can measure the pressure in the pulmonary artery. Now further along, as the artery moves forward, the balloon, it wedges itself into one of the branches of the pulmonary artery, and this will block the blood flow from the pulmonary artery, and now the pressure sensed by the tip of the catheter is gonna be equal to that of the left atrium, okay? So the pressure sensed by the pulmonary artery catheter when it wedges itself into one of the branches of the pulmonary artery is known as pulmonary capillary wedge pressure, which is essentially equal to that of the left atrium. So these are all the pressures that can be measured using Swan-Ganz catheter. And I've already mentioned Swan-Ganz catheter can not only be used to measure the pressure, but it can also be used to measure the mixed venous oxygen saturation. So how does it do that? But first, let's briefly explain what is mixed venous oxygen saturation. So I'll draw a very rough sketch of the heart. So these are the two atrium and these are the two ventricles of the heart. There are arteries leaving the heart, and these arteries, they are going to perfuse the tissues. So let's say this is the tissues, and there are veins arising from the tissues, and they will take blood back to the heart, okay? So here we have the heart, these are the arteries, this is the tissues, and these are the veins, okay? So oxygenated blood are gonna come from the arteries into the tissues. So the oxygenated blood are gonna come into the tissues, and the tissue cells, they're gonna extract oxygen from the blood, right? So the tissue cells will extract oxygen in the amount they need from the arterial blood. And not all oxygens are going to be utilized. Some of them are going to be left unused, and this leftover oxygen are going to pass through the veins and they're going to flow back into the heart, okay? So these are the leftover oxygens that are left unused by the tissues. So the mixed venous oxygen saturation is the percentage of oxygen that is present in the veins, okay? So this amount of this oxygen that are left unused by the tissues is the mixed venous oxygen saturation. Now, what we can derive from here is that if the tissues, due to some reasons, if they extract more oxygen from the blood, okay, if the tissues extract more oxygen from the blood, then less oxygen is going to be passed into the venous blood, okay? So if there is less oxygen in the venous blood, then the mixed venous oxygen saturation is going to go down, okay? So in conditions such as, if let's say if there is decrease in the cardiac output, okay, so if there is fall in the cardiac output, less blood is going to come from the arteries, which means the tissues are going to be underperfused. If the tissues are underperfused, they tend to extract more and more oxygen from the blood. And if they extract more oxygen from the blood, less oxygen are going to be present on the venous blood. So hence the mixed venous oxygen saturation is going to go down. Okay, so the mixed venous oxygen saturation is going to go down when there is cardiac output, fall in the cardiac output. And this can be seen in case of cardiogenic shock. Okay, so in the cardiogenic shock, the heart cannot pump out the blood. So if there is fall in the cardiac output, and the mixed venous oxygen saturation also falls. And this can also be seen in case of hypovolemic shock. In the hypovolemic shock, there is less blood, which means less blood is coming out from the heart. The tissues are going to extract more oxygen, and the mixed venous oxygen saturation is going to go down. So in case of cardiogenic shock and the hypovolemic shock, there is fall in the mixed venous oxygen saturation. Whereas in case of distributive shock, in the distributive shock, the tissues are going to extract less oxygen, okay? So due to some reasons, such as hyperdynamic circulations or abnormal circulations of the blood into the tissues are unable to extract enough oxygen from the blood. So they're going to extract less oxygen, which means more oxygen are going to be present on the venous blood, and this will increase the mixed venous oxygen saturation. So in case of distributive shock, the mixed venous oxygen saturation is going to go up. Okay, so in the cardiogenic and the hypovolemic shock, the mixed venous oxygen saturation is going to go down, whereas in case of the distributive shock, it's going to go up. So the Swan-Ganz catheter, when inserted inside the heart, can be used to take sample of this blood. Okay, so these are the same blood that have just returned from the tissues. So when you take sample of this blood, then it can be used to measure the mixed venous oxygen saturation. So that's how Swan-Ganz catheter helps to measure mixed venous oxygen saturation. So these are all the parameters here that can be measured using Swan-Ganz catheter. We have the right atrial pressure, right ventricular pressure, pulmonary artery pressure, and pulmonary capillary wedge pressure, and mixed venous oxygen saturation. I've written all of these along with their normal value here. And later in the video, we'll learn how we can use these parameters to differentiate the types of the shock. Now let's learn about the cardiogenic shock. In the cardiogenic shock, the heart ventricles cannot pump enough blood out from the heart. So the cardiac output is gonna be low, okay? And we know that blood pressure is equal to the product of cardiac output and systemic vascular resistance. So in the cardiogenic shock, as the cardiac output goes down, now our body will initiate sympathetic response, and as a result, our arteries are gonna be constricted and so on. The systemic vascular resistance is gonna go up, okay? So there's gonna be high systemic vascular resistance. So in any case of low cardiac output, the systemic vascular resistance is gonna go up, okay? So in the cardiogenic shock, there is low cardiac output and high systemic vascular resistance. Now talking about the cardiac pressures, so these are the pressures that we just learned that are measured using the Swan-Ganz catheter, okay? In the cardiogenic shock, the heart cannot pump enough blood, so the blood are gonna be pulled inside the ventricles or the chambers of the heart. So the blood are gonna be staying here in the chambers of the heart, and they will exert pressure into the heart walls, heart chambers, and these are gonna increase the cardiac pressure, okay? So if there is increase in the pressure in the ventricles, this pressure is going to be transmitted into the atrium, so the pressure in the right atrium is also going to be increased. Same thing happens on the left side of the heart, and so there is increase in the pulmonary capillary wedge pressure as well. And the cardiogenic shock can be seen in cases of myocardial infarction or advanced heart failure. Now let's talk about the hypovolemic shock. In the hypovolemic shock, hypo means low, volume means blood, volume means volume, and emic means blood. So there is low blood volume. As a low intravascular blood volume, the cardiac output is going to be low as well. And we just learned the sympathetic response is going to be activated, and it's going to increase the vascular resistance. Now, unlike the cardiogenic shock, in hypovolemic shock, the cardiac pressures are going to be low, okay? So the reason is that in the hypovolemic shock, the blood volume itself is low. So if there are less amount of blood, then less pressure is going to be exerted into the heart chamber, so the cardiac pressure is going to be low. And this is classically seen in dehydration, hemorrhage, high fever where there is insensible loss of fluids from the body, and burns. Now the third type of shock is distributive shock. In the distributive shock, the major problem is the peripheral vasodilation, okay? So let's take an example of the septic shock. In a septic shock, an infective organism, is going to produce toxins that are going to dilate the blood vessels. It's going to destroy the endothelium as well as dilate the blood vessels. And this calls for more inflammatory cells into the infection site of infection. And the inflammatory cells are going to also produce more vasodilators and more inflammatory mediators, which are going to further dilate the blood vessels. So as the blood vessels are dilated, the systemic vascular resistance is going to go down, okay? So there is going to be low systemic vascular resistance in the distributive shock. And as a response, we know that blood pressure is equal to cardiac output multiplied by systemic vascular resistance. So if the systemic vascular resistance is going to go down, then as a response, the cardiac output is going to go up. So we can see high cardiac output in case of distributive shock. So the most common type of distributive shock is the septic shock, which is due to infection. It can also be due to allergic reaction. In that case, it's known as anaphylactic shock. Or if there is any neurogenic defects like intracerebral bleeding, then this can lead to neurogenic shock. And about the cardiac pressures in the distributive shock, they are either normal or slightly low, okay? So the cardiac pressures are not going to be affected that much in case of distributive shock. So here I have compared the different hemodynamics of the three types of shock. We have the cardiogenic shock, hypovolemic, and the distributive shock. Now here I have not included the obstructive shock because we diagnose obstructive shock using other methods rather than the hemodynamics. So Talking about the blood pressure, it's going to be low in all the three types of shock, because as a definition, we know that shock is a life-threatening fall in the blood pressure. So the blood pressure is going to go down, and as a result, the heart rate is going to go up. Okay, so the blood pressure and heart rate is same for all three types of shock. Now in the cardiogenic shock, the cardiac output is going to go down because there is problem in the ventricles. The ventricles cannot contract, which means less blood is leaving out from the heart, so the cardiac output is going to go down. And as a response to that, our sympathetic system is going to be activated. They are going to constrict the arteries, so the systemic vascular resistance is going to go high in the cardiogenic shock. And talking about the pressures, the blood remains in the ventricles and they're going to exert pressure there, so the pressure in the chambers of the heart is going to increase. So we have increase in the right ventricular pressure, increase in the right atrial pressure, and also the pulmonary capillary pressure are going to go up in the cardiogenic shock. Now in the hypovolemic shock, there is less blood volume, so the cardiac output is going to be low, and as a response, the systemic vascular resistance is going to go high. But unlike the cardiogenic shock, the pressure in the heart are going to go down because there are not enough blood to exert pressure in the chambers of the heart in the hypovolemic shock. Now in case of distributive shock, as we just learned, the major problem is the peripheral vasodilation. So there is diffuse vasodilation which will reduce the systemic vascular resistance. So the systemic vascular resistance is going to go down, and as a result, the cardiac output is going to go up in case of the distributive shock. And for the pressures, they are either going to be normal or slightly decreased. Now in exam, if they ask you to determine the types of shock, then the first thing you have to do is look for the systemic vascular resistance. When you look at the systemic vascular resistance, if it is low, then it might be distributive shock, okay? Because systemic vascular resistance is low only in case of the distributive shock, since there is peripheral vasodilation. If it is high, look for the pressures. The cardiac pressures, most probably they'll give the value of pulmonary capillary wedge pressure. So when if the pressures are high, then it can be cardiogenic shock, and if the pressures are low, then it can be hypovolemic shock. Now under the physical examination, in the cardiogenic and the hypovolemic shock, we know there is low cardiac output and high systemic vascular resistance, which means there is low tissue perfusion, which can lead to cold skin. Whereas in case of the distributive shock, there is high cardiac output and low systemic vascular resistance, so there is going to be warm skin. In the cardiogenic shock, as I already explained, there is going to be increase in the cardiac pressure, so the cardiac pressure are going to go up. So if there is increase in the right atrial pressure, it can manifest as elevated jugular venous pressure. Since the right atrium is directly connected with the jugular veins, so the increase in the right atrial pressure can increase the pressure in the jugular veins, so there is going to be elevated jugular venous pressure. If there is elevation of the left atrial pressure, then it can manifest as pulmonary rales, which are rattling sounds heard when a person inspires. Now lastly, talking about the obstructive shock, there is obstruction to the blood flow from the heart, and this can be seen in many cases of cardiac tamponade, tension pneumothorax, and massive pulmonary embolism. So now what really happens here is that in case of cardiac tamponade, so this is the heart, and our heart is surrounded by a layer known as pericardium. So this is the pericardium, and in between the heart and the pericardium, we have this space known as the pericardial space. Now in case of cardiac tamponade, this pericardial space, it is filled by fluid or blood, okay? So the pericardial space is filled by different effusions or blood, which can compress the heart, okay? So all these fluids and the blood, they are going to compress the heart, not allowing the heart to dilate properly. If the heart cannot dilate, if the ventricles of the heart cannot dilate, then they cannot accommodate more blood, which means there will be less blood in the ventricles. If there is less blood, then less blood is going out from the ventricles as well. So there is low cardiac output in case of obstructive shock. And as a response, there is going to be high systemic vascular resistance. So In the cardiac tamponade, the fluids in the pericardial space are going to compress the heart, not allowing it to dilate. So the less there is a defect in the ventricular filling, and there is going to be low cardiac output. Same is the case with the tension pneumothorax, where there's going to be high pressure in the thorax, which is going to compress the heart. Whereas in case of the massive pulmonary embolism, the defect is actually present in the lungs. Okay, so we have the heart here. So this is the right heart, this is the left heart, and this is the lungs. So the right side of the heart will supply blood to the lungs, and our lungs is going to purify that blood, and it's going to send it back to the left side of the heart, actually into the left atrium. Okay, so what really happens in case of pulmonary embolism is that there is a blood clot in the lungs. This blood clot is going to obstruct the blood flow, which will lead to pulmonary edema. And if there is pulmonary edema, this edema is going to block the flow of blood from the right side of the heart to the left side of the heart. So less blood will be coming into the left side of the heart, which means the cardiac output is going to be low. And this will lead to obstructive shock. Now, the features might be similar to that of the cardiogenic shock, but here the contractility of the heart is normal. Now, talking about the treatment of shock. In the cardiogenic shock, since the heart cannot contract properly, we can give inotropes such as milrinone or dobutamine. In the hypovolemic shock, there is less intravascular blood volume, so we can give blood transfusion or IV fluids. In the distributive shock, the problem is peripheral or diffuse vasodilation, so we can give vasopressors such as phenylephrine, epinephrine or norepinephrine. In case of obstructive shock, we need to relieve the obstruction. So if there is tamponade, we need to treat the tamponade, treat the embolism, or if there is tension pneumothorax, then treat the tension pneumothorax. So now coming back to this question, a 48-year-old woman is admitted to the intensive care unit with hypotension. She is receiving no vasoactive agents and is breathing room air. Blood pressure measured by an intra-arterial line is 70 by 45 millimeter of mercury. So you can clearly say that she is hypertensive. Her pulse is 120 per minute and regular. Invasive hemodynamic monitoring is established and initial readings are as follows. So the pulmonary capillary wedge pressure given is 6 millimeter of mercury. Normally it should be between 6 to 12 millimeter of mercury. So you can say it is either normal or just slightly less than normal. Okay, and the mixed venous oxygen saturation given here is 78%. The normal is between 65 and 75. So there is definitely increase in the mixed venous oxygen saturation. So which of the following is the most likely cause of this patient's condition? So now coming to the first option here, in the cardiogenic shock. Now we know in the cardiogenic shock, the heart is not pumping out the blood, and the blood are going to exert pressure in the cardiac chamber. So there's going to be increase in the pressure, which is not seen here. And also there is low cardiac output in the cardiogenic shock. So the mixed venous oxygen saturation should have been low. Okay, but in this case it is increased. So cardiogenic shock is not an option here. And next, moving on to the pericardial tamponade. In the pericardial tamponade, there are fluids that are surrounding the heart in the pericardial space, okay? And those fluids are going to exert pressure into the heart, which means the pressure inside the heart is going to increase. And also, due to less ventricular filling, the cardiac output is going to go down, and hence the mixed venous oxygen saturation is also going to go down, but that's not the case here. So pericardial tamponade is also incorrect. Now, on the option C, we have right ventricular infarction. In the right ventricular infarction, the right ventricle cannot pump blood into the left ventricle. So if there is less blood in the left ventricle, then the cardiac output is going to be low. If the cardiac output is low, the mixed venous oxygen saturation is going to go down as well, but it is increased here. So this is also incorrect. Now in the D, we have volume depletion, or we can also call it as hypovolemic shock. In the hypovolemic shock, the blood exerts less pressure into the cardiac chamber, so the pressure should be low, and also there is decrease in the cardiac output because there is less volume of the blood, and if there is a decrease in the cardiac output, the tissues are going to extract more oxygen from the blood, and the mixed venous oxygen saturation is going to go down, but it's increased here, so this is also incorrect. And now lastly we come to the septic shock. So in the septic shock, we know that this is a form of a distributive shock, so there is problem in the distribution. Now in the septic shock, as we have learned earlier, the cardiac pressures, they are going to be either normal or slightly less than the normal, and the cardiac output here is going to increase if there is increase in the cardiac output in the septic shock, and also there is infection due to which the tissues in the body cannot extract oxygen from the blood properly, so the mixed venous oxygen saturation is gonna go high, which is obviously seen in this case here. So the correct answer here is gonna be septic shock. Thank you.